Good morning, everyone. I am Cruz, a 40 resident from St. Luke's Global City, and for today, I'll be covering Chapter 26 of the 5th edition of Brand, The Cardiac Masses. This chapter is new to the 5th edition of Brand, as most of the things that I'll be reporting are coming from the latest edition of Brand, as well as several journals. Here's the outline of my report. First would be my introduction, and then we'll tackle benign cardiac tumors, and after which we'll go to the malignant cardiac tumors. I made my presentation a case-based format for better understanding and easier digestion for the trainees, especially the juniors. Most of my cases will be coming from journals I listed at the end of my presentation. Cardiac tumors, benign and malignant, are rare, with an estimated prevalence of only 0.002% to 0.3% at autopsy. Approximately 75% of primary cardiac tumors are benign. The other 25% of cardiac tumors are malignant, 95% of these are sarcomas, and 5% are lymphomas. The table on your right summarizes the incidences of the primary cardiac tumors. Here is an algorithm I got from the book. Cardiac mass is divided into tumor and tumor-like lesions. For tumor-like lesions, we have thrombus formation, vegetation, etc. I'll not be discussing this part and will be focusing more on the tumors. Tumors can be primary or secondary. Primary is subdivided into benign and malignant tumors. For the primary benign tumors, we have myxoma, lipoma, fibroma, rhabdomyoma, etc. For malignant tumors, we have angiosarcoma, rhabdomyosarcoma, lymphoma, etc. Secondary tumors are usually caused by metastasis. It is important to know the typical location of the cardiac masses. As Dr. Anil Ahuja is always saying during his talks, location, location, location. You can narrow down your differentials based from the location of the tumor. So please remember this slide. We will now proceed to our first case. The first case is a 40-year-old female who complained of shortness of breath with activity. Upon auscultation, low-pitched sound is heard during early or mid-diastole. Chest X-ray is unremarkable, so the attending physician requested for a 2D echo, which shows a mass at the interatrial septum into the left atrium. Upon further investigation for this patient, they requested a CT scan and MRI. Axial post-contrast CT scan demonstrates a broad-based, hypodense mass extending from the interatrial septum into the left atrium. MRI shows iso-intense signal on T1 weighted images, hyper-intense signal on T2 weighted images, with and without fat saturation, and heterogeneous enhancement on early post-contrast T1 weighted imaging. After surgical removal, pathology was consistent with an atrial. Cardiac myxoma is the most common primary cardiac tumor and represents 50% of all benign cardiac masses and 25% of all primary cardiac tumors. It occurs in the 4th to 7th decades of life, and approximately 60% of affected patients are female. Myxomas can be seen in patients with Carney complex. They are commonly intracavitary, with 75 to 80% found in the left atrium, with majority arising from the interatrial septum near the fossa ovalis. The key imaging feature in the diagnosis remains in its location and relationship with the interatrial septum. Imaging features of cardiac myxoma are as follows. For its location, the typical location is in the left atrium, interatrial septum attached to the fossa ovalis. CT demonstrates a hypodense lesion. T1 is iso-intense, T2 is hyperintense, perfusion is mild, while late gadolinium enhancement is heterogeneous. Let's proceed with the second case. The second case is a 45-year-old male, asymptomatic, with an incidental finding of an echogenic mass at the myocardium seen at the 2D echo. MR images in a 45-year-old man who had a suspected myxoma at echocardiography show a homogeneous high signal intensity relative to the myocardium on T1 weighted imaging that markedly suppressed with the application of an additional fat saturation pre-pulses. Note the similar signal intensity of surrounding chest wall fat on T1 and T2 weighted images. There was no enhancement with contrast agent administration. The imaging features are typical of a lipoma. Cardiac lipomas are benign lesions which constitute approximately 10% of all primary cardiac tumors. Majority of cases arise from the epicardial surface and extend outward into the pericardial space. Both cardiac lipomas and lipomatous hypertrophy of the interatrial septum will demonstrate identical signal characteristics. The location of the lesion within the interatrial septum with sparing of the fossa ovalis will allow differentiation of the lipomatous hypertrophy from a true lipoma. The cardiac lipoma imaging features are listed below. For its location, it's endocardial, intramyocardial, or epicardial, in or around any chamber. The CT would demonstrate a homogeneous lesion with fat density. T1 and T2 weighted images are hyperintense. Perfusion is absent, while late gadolinium enhancement is also absent. Case 3 is a 30-year-old female with syncope and unexplained hypertrophy at the anterolateral wall at echocardiography. MR imaging shows that the mass was intramyocardial with local mass effect. It is isointense relative to the myocardium on T1 weighted imaging. Hypointense on T2 weighted imaging. On perfusion images, the mass did not show any substantial contrast enhancement with gadolinium-based contrast agent, suggesting a vascularity. The most characteristic feature was diffuse homogeneous enhancement of the mass on late gadolinium and images, suggestive of a fibroma, which was confirmed at histologic examination. Fibromas are the second most common cardiac tumors in infants and children. It's a non-encapsulated fibrous tumor composed of neoplastic fibroblast and abundant collagen. Its common location is the left ventricular wall or interventricular septum, measuring between 2 to 7 centimeters. It is associated with Gorlin syndrome. Here are the imaging features of fibromas. For its location, it's usually on the ventricles or in the intramyocardium. CT shows homogeneous low attenuation mass. T1 is isointense. T2 is hypointense. Perfusion is absent while late gadolinium enhancement is intense. Case number 4 is a 22 weeks age of gestation with the note of hyperechoic mass in the interventricular septum on prenatal cardiac echocardiogram. Fetal MR images obtained at 34 weeks age of gestation of the same patient shows a large mass rising from the interventricular septum. Oblique postnatal echocardiogram also shows a large echogenic mass in the ventricular septum that fills almost the entire right ventricle and a portion of the left ventricle. These findings are consistent with a rhabdomyoma. Rhabdomyomas are the most common primary tumors in infants and children. It accounts for 50% to 75% of pediatric cardiac tumors. They are hamartomas of altered and large cardiac myocytes, which arise as small intramural nodules in the ventricular myocardium, measuring between 1 and 3 centimeters on average. There is a strong association between cardiac rhabdomyomas and tuberous sclerosis, an autosomal dominant disease characterized by benign hamartomas in multiple organ systems. For the imaging features of rhabdomyoma, it is usually located in the ventricles, intramyocardial or intracavitary. CT would demonstrate smooth nodules in the myocardium. T1 is iso-intense, T2 is iso to hyperintense, perfusion is absent to mild, late gadolinium enhancement is absent to minimal. Case number 5 is a 60-year-old male who has progressive dyspnea on exertion, also has chest pain. Chest X-ray shows cardiomegaly in globular configuration, while 2D echo revealed massive pericardial effusion with cardiac tamponade. Axial and coronal post-contrast CT images demonstrates a heterogeneous enhancing mass in the right atrioventricular groove with a pericardial effusion. Cardiac MRI shows a heterogeneous hyperintense lesion on the SSFP and T2 weighted images with avid enhancement on both the perfusion and the late gadolinium enhancement sequences. The central non-enhancing area within the mass represents necrosis. The features are typical of a cardiac angiosarcoma. Cardiac angiosarcomas are the most common differentiated cardiac sarcomas, comprising of nearly 40% of cases. It's a malignant tumor of mesenchymal cells characterized by ill-defined anastomotic vascular spaces lined by atypical endothelial cells. It's the only cardiac sarcoma that predominantly arises in the right atrium in the region of the right atrioventricular groove. Cardiac angiosarcoma imaging features. It's commonly located in the right atrium or in the ventricles. CT would show hemorrhagic lesion. T1 is heterogeneous, while T2 is hyperintense. Perfusion is intense, while late gadolinium enhancement is heterogeneous. We are down to the last two cases. Case number 6 is a 9-year-old girl with worsening of facial swelling and venous distension on the chest and face. Echocardiogram shows a large mass extending from the superior vena cava and filling almost the right entire atrium. Transaxial and sagittal CT images show a large intracardiac mass predominantly in the right atrium. A portion of the mass extends into the right ventricle. There is extensive venous obstruction due to mass extension into the superior vena cava, both brachiocephalic veins and the azygos vein. A large anterior mediastinal soft tissue component containing calcifications are also seen. The biopsy of the right atrial mass demonstrates a large B-cell lymphoma, and the patient underwent chemotherapy. Primary cardiac lymphoma is a lymphoma exclusively involving the heart and/or the pericardium. It is usually the non-Hodgkin B-cell type, most commonly occurring in the immunocompromised patients. Secondary cardiac involvement by lymphoma, either through direct extension or via hematogenous spread, is more common than primary cardiac lymphoma. It typically involves the right heart, particularly the right atrium, and has a predilection for the atrioventricular groove in the right, similar to angiosarcoma. Primary cardiac lymphoma imaging features. The location is anywhere but classically near the right atrioventricular groove. CT would show infiltrating lesion on low and isoattenuating to the myocardium. On T1 weighted images, it's hypointense to isointense. T2 is iso to hyperintense. Perfusion is absent to mild. On late gadolinium enhancement is variable, at times none. For the last case, case number 7, is a 64-year-old male, cachectic, and echocardiogram demonstrates a right atrial mass. An irregular lesion was confirmed in the right atrium at cine-MR imaging. On transaxial sections, the right atrial mass was seen to extend up to the inferior vena cava, and additional metastases were seen in the liver and lungs. There was low signal intensity on T1 weighted images and high signal intensity on T2 weighted images. The cardiac mass and the pulmonary metastasis share the same T1, T2 signal pattern, suggesting they were part of the same underlying disease. The uptake of contrast agent in the metastasis was heterogeneous, with the centrally enhancing core and peripheral capsule at late gadolinium imaging. The contrast agent uptake also delineated the extent of the mass in the inferior vena cava. Post-mortem examination confirmed advanced colorectal adenocarcinoma with pulmonary, hepatic, and cardiac metastases. Cardiac metastases are 20 to 40 times more common than primary cardiac tumors. Most patients have no cardiac symptoms, and the metastases are discovered at postmortem. Most common malignancies to spread to the heart are lung and breast cancers, lymphoma, and malignant melanoma. The metastatic spread to the heart can occur by direct invasion, hematogenous, transvenous via the great veins, or via mediastinal lymphatics. The imaging features of cardiac metastasis. The location can be endocardial, intramyocardial, or epicardial, or around any chamber. The CT would demonstrate a infiltrative lesion. T1 weighted imaging would be variable, but commonly hypointense. T2 would be hyperintense. On perfusion, it's variable, mild to hyperintense. On late gadolinium enhancement, it's heterogeneous. So we have discussed several disease entities, namely from the benign tumors, myxoma, lipoma, rhabdomyoma, and fibroma. For the malignant primary tumors, we discussed about angiosarcoma and lymphoma. Also, we discussed about cardiac metastases. Here is a summary table of the cardiac mass imaging features on CT and MRI. You can find this in the 5th edition of Brand. You should familiarize with this table, as I think this will be asked in the future exams. Here are my other references. And with that, I end my presentation. Thank you and have a nice day.
Thank you so much, Dr. Khalil Cruz. That was an exceptional lecture. And don't we all agree that this is an excellent lecture? So let's move forward to welcome Dr. Aryan Landicho. Dr. Aryan, are you ready?
Hi, doctor. Good morning. Are my slides clear?
Yes, Dr. Aryan. Thank you.
Apologies. Yes, po, Doc. Apologies for earlier, po, Doc. So to continue, we'll be continuing where we left off in the discussion of chapter 25. So the coverage is quite lengthy, as I've said earlier, but we shall touch on the key points, starting with MRI in coronary artery disease. So coronary CTA is the primary non-invasive technique for evaluating the coronary arteries, but coronary MR angiography is also a potential alternative. Although it's not commonly used for CAD in most institutions, it is used to assess anomalous coronary arteries and coronary artery aneurysms, especially in the pediatric population or those with severe contrast allergies. These are because coronary MRA can be performed without IV contrast and patients are not exposed to ionizing radiation. However, compared to CTA, limitations include reduced spatial resolution, longer exam times, and operator dependency. At 1.5T, blood appears bright on steady free precession sequences or the SSFP due to its inherent T2, T1 weighting. Hence, there's no need for contrast. But for 3T, gadolinium contrast is used. So for the assessment of the myocardium, MRI is considered the gold standard for evaluating cardiac function, differentiating between the non-ischemic and the ischemic etiologies. But for this session, we shall focus on the ischemic etiologies. Given a patient with a suspected ischemic cardiomyopathy, one of the four main goals of a radiologist is to evaluate cardiac function and morphology. The functional evaluation is performed using an SSFP sequence or GRE. In most instances, it is obtained in 2, 3, and 4 chamber planes, but the mainstay for the evaluation is the short axis plane. SSFP imaging allows the detailed assessment of wall motion and thickness. So with a myocardial infarct or ischemia, it will manifest as a wall motion abnormality localized to a specific vascular territory. Now, depending on the severity of the injury, the wall motion can be described as akinetic, hypokinetic, or dyskinetic. In the setting of a recent MI, there may be increased subendocardial signal intensity in the myocardium on T2-weighted sequences due to the myocardial edema. These T2-weighted sequences are performed using a double inversion recovery, or what we call black blood, used to null the signal in the blood pool, or a triple inversion to null the signal in both blood and fat. Edema can also sometimes be seen on SSFP due to its T2-T1 weighting. So while myocardial thinning often suggests scarring, it does not necessarily equate to non-viability. Non-viability, or viability rather, is assessed using delayed enhancement imaging. For the first pass myocardial perfusion imaging, it is performed during the administration of IV gadolinium. In areas of ischemia and infarct, subendocardial predominant hypoperfusion is often seen, corresponding to the regions of wall motion abnormality identified in cine imaging. 10 to 15 minutes after injection, delayed images are usually acquired. Although gadolinium is an extracellular agent, this contrast can accumulate in areas where there has been acute myocyte injury, secondary to cell membrane disruption, as in acute or subacute infarct, or in areas with an increased interstitial space, such as areas of scarring, as seen in chronic infarct. The extent of late gadolinium enhancement, or LGE, is directly related to the likelihood of successful revascularization. Less than 50% is associated with functional recovery after revascularization. More than 50% means it's less likely to respond to revascularization. And if involving the entire thickness, as with large transmural infarcts, especially in the LED distribution, left ventricular aneurysms are more likely to happen with propensity to develop thromboembolism. For our first case, this is a 77-year-old male with transmural LED territory infarct. Figure A is a 2-chamber, while B is a 4-chamber view. Both are seen in SSFP sequences demonstrating thinning of all the apical segments of the left ventricle, pointed by the white arrows, and these are dyskinetic. The anteroseptal segment at the mid-cavity level is also thinned and akinetic, pointed by the yellow arrow. The white arrowhead points to the anterior segments at the mid-cavity level, and the yellow arrowhead to the base, which are both hypokinetic. Now, a low signal mass in the left ventricular apex, pointed by the black arrows, is consistent with a thrombus. From the same patient, gadolinium delayed enhancement images, image C is a 2-chamber, while D is a 4-chamber view. There is transmural enhancement of the dyskinetic to akinetic segments, demarcated by the white arrows, consistent with non-viable myocardium. The hypokinetic anterior segments at the mid-cavity, pointed by the white arrowhead, and base yellow arrowhead, show no enhancement. Therefore, these could improve function with revascularization. The apical thrombus, pointed by the black arrows, is again devoid of signal. Next, microvascular obstruction. It is a specific form of myocardial reperfusion injury occurring after therapy for an acute MI. Primarily, it is secondary to the release of cytotoxic mediators. It commonly occurs nearly immediately after reperfusion and can increase in size and extent from 48 hours up to 1 month after reperfusion. Since the contrast cannot diffuse into these areas on LGE imaging, these areas of MO appear as dark, non-enhanced areas surrounded by enhancing infarct. It's an indicator of severe myocardial injury, often leading to adverse left ventricular remodeling, and it's an independent poor prognostic factor. Now we move on to the treatment of CAD. Compared to coronary angioplasty alone, coronary stents are larger, create a larger residual diameter, reducing the rate of restenosis. Complications include in-stent restenosis and stent thrombosis. CTA is used to evaluate for stent occlusion and restenosis. More likely to be evaluated are stents more than or equal to 3 millimeters in diameter. In a large meta-analysis using 64 slides, overall negative predictive value is high at 97%, but with low positive predictive value at 53%. The next case is a 59-year-old woman post-CAD stenting of the LAD, presenting with chest pain. The image is a curved MPR image through the LAD showing a patent stent pointed by the white arrow with no in-stent restenosis. However, distal to the stent, there is a severe stenosis marked by the white arrowhead. Another patient, a 66-year-old man, also post-coronary stenting of the LAD. This curved MPR through the LAD now demonstrates an area of hypoattenuation in the distal aspect of the stent due to in-stent restenosis, pointed by the white arrow. There are also moderate stenoses in the LAD proximal and distal to the stent, demarcated by the white arrowheads. Next, we move on to coronary artery bypass graft. It has remained the definitive treatment for advanced CAD. ECG-gated CTA is an excellent tool for assessing the patency, which is critical for long-term survival. In a study, internal memory grafts have greater patency rate of 85% after 10 years compared to 61% of the saphenous vein grafts. In most instances, the left in IMA is used due to its proximity to the left ventricular apex. We have now another case of a 60-year-old man post-cabbage. Curved parasagittal MIP image from a gated CTA shows a patent left IMA bypass graft demarcated by the white arrows. It arises from the left subclavian artery pointed by the red arrow, anastomosing with the distal LED demarcated by the black arrow. Now further down, we can appreciate good opacification of the LED distal to the anastomosis marked by the black arrowhead. Saphenous vein graft is attached as a free graft to the ascending aorta and coronary artery distal to the site of obstruction. While an SVG can supply a single vessel, it can also serve as a sequential or jump graft. A rightward directed SVG usually is toward the RCA distribution and will anastomose with the PDA, while the leftward directed SVG can anastomose with various vessels. This is a 64-year-old woman with a history of cabbage. The image is an axial oblique image through the ascending aorta, showing a small outpouching from the aorta pointed by the white arrow, with a subtle thrombosed saphenous vein to diagonal bypass graft marked by the white arrowhead. The appearance of these small outpouchings from the aorta has been referred to as the Nubbin sign. Now we move on to aneurysms of the saphenous vein graft. This usually occur after within first 5 years, approximately for 10%, or in nearly 70%, they occur more than 10 years after the initial cabbage. It is primarily due to accelerated atherosclerosis, so we can surmise that it is a late complication of cabbage. Case reports indicate average SVG aneurysm diameter is more than 6 centimeters, and the most common distribution is the SVG to RCA anastomosis. We now have a chest X-ray, PA and lateral, of a 77-year-old man showing a well-rounded mass in the anterior mediastinum, pointed by the white arrows. Given the location and the adjacent coronary artery bypass clips marked by the black arrow, this is concerning for a bypass graft aneurysm. Further evaluation was done, and from the same patient, this coronary oblique MPR image from a gated CTA in fact shows the SVG aneurysm marked by the white arrows. Then we have pseudoaneurysms, which is a rare complication, and most commonly they occur due to graft breakdown and dehiscence. Compared to SVG aneurysms, they tend to occur at the proximal or distal anastomotic sites and within the first weeks to months of after surgery. This next case is that of a 40-year-old man with worsening chest pain 2 days after surgery. Image A is an axial non-contrast image from gated CTA demonstrating a heterogeneous fluid collection surrounding the aortic root with areas of high attenuation suggestive of blood products. Now, this axial image from the same patient at the same level after administration of contrast shows contrast extravasation near the right sinus of valsalva, pointed by the white arrow. So what happened to this patient? He underwent reduced sternotomy where they discovered that the RCA SVG graft had dehisced from its aortic anastomosis. Moving on to coronary artery aneurysm and pseudoaneurysm. Coronary artery aneurysm is defined as more than 1.5 times the adjacent normal coronary artery. Atherosclerotic disease is the most common etiology in the adults, but in the pediatric population, Kawasaki disease is the most common cause. The smaller coronary artery aneurysms may decrease in size or resolve in patients with Kawasaki disease, but giant aneurysms more than 8 millimeters do not regress and can lead to rupture, thrombosis, or in some instances, MI and even death. We have here a sagittal oblique MPR image through the right circumflex artery in an 80-year-old man showing extensive atherosclerotic disease with multiple RCA aneurysms. These are pointed by the white arrows, and the partially visualized left anterior descending artery is also aneurysmal, marked by the white arrowhead. Pseudoaneurysm is rare, but the most common cause is iatrogenic due to coronary catheterization. Now we have a case of a 60-year-old, day 1 post-cardiac catheterization. This image is an axial oblique MPR with diffusely aneurysmal and calcified coronary arteries showing a defect in the posterior wall of the left main coronary artery pointed by the white arrow. There is surrounding hematoma demarcated by the black arrows, and the injury was thought to be iatrogenic. Moving on to coronary artery dissection, there are 3 main causes. The most common is percutaneous intervention such as angioplasty. These dissections are limited and can be usually successfully treated with stent placement. Type A aortic dissections involve the ascending aorta and can extend into the aortic root. Obstruction of coronary blood flow can occur via 2 mechanisms. First, the intimal flap directly covering the ostium of the coronary artery, and second, the dissection extending from the aorta into the coronary artery. The third main cause is the spontaneous CAD, usually affecting younger women and commonly associated with pregnancy, postpartum, and in patients undergoing intense exercise. This is now a case of a 55-year-old male with hypertension. A is an axial oblique image through the aortic root showing type A dissection. The dissection flap pointed by the black arrows extend into and occludes the left anterior descending coronary artery marked by the red arrows. Fortunately for this patient, he had an uncommon coronary artery variant where the LAD and LCX have separate ostia from the left sinus of valsalva, And because of this, the left circumflex remained patent, marked by the white arrow. Next case is a 24-year-old woman after giving birth to her second child. Image A is longitudinal image through the proximal LED showing soft tissue attenuation surrounding the vessel corresponding to the thrombosed false lumen demarcated by the white arrows. This compresses the true lumen marked by the black arrow. There are also few areas of contrast outpouchings that represent persistent filling of the false lumen marked by the red arrows. The left ventricle is severely dilated, consistent with the patient's ejection fraction of 31%. Finally, for the mechanical complications of MI, there are three: the left ventricular free wall, ventricular septal, and papillary muscle rupture. And these are catastrophic mechanical complications. It usually occurs within the first week after infarction and may be lethal if not quickly recognized and treated. A left ventricular pseudoaneurysm, also referred to as left ventricular free wall rupture, occurs when there is a tear through the myocardium that is contained by the adjacent pericardium or scar tissue. MI is the most common cause. It is important to differentiate true from pseudoaneurysm due to differences in treatments and outcomes. In general, true aneurysms have a broad neck, whereas pseudoaneurysms usually have a narrow neck that has a diameter less than 50% of the maximal diameter of the distal outpouching. This is now a case of a 61-year-old male with recent LED territory infarct. Coronal oblique reformat shows the narrow necked tear through the left ventricular myocardium pointed by the white arrow. Distal to it is a distal pseudoaneurysm marked by the yellow arrowhead, and surrounding hemopericardium is appreciated, demarcated by the white arrowheads. Next is a coronal oblique image through the base of the heart in a 61-year-old man. There is a large wide-mouthed true aneurysm of the inferior wall, which is surrounded by thin myocardium, pointed by the white arrows. The RCA is chronically occluded, pointed by the yellow arrow. Next is a 78-year-old woman who developed worsening shortness of breath 4 days after LED territory infarct. This four-chamber image from a cardiac CTA shows a large defect in the anteroseptal segment at the base, pointed by the black arrow. This is consistent with the post-infarct ventricular septal rupture. The edges of the myocardium adjacent to the rupture are hypoattenuating due to the infarct, pointed by the red arrow. Unfortunately for this patient, she died 1 day later. For our last case, this is an AP radiograph of a 49-year-old woman with severely worsening dyspnea 7 days post-RCA territory infarct. There is asymmetric edema, most notably in the right upper lung, and on four-chamber view from a bedside ECG, is demonstration of a flare posterior leaflet pointed by the white arrow, leading to severe acute mitral regurgitation. The anterior leaflet is still attached to its chordae, the yellow arrow, and papillary muscle, yellow arrowhead. The rightward and superior direction of the jet causes this characteristic finding. Once again, we have briefly touched on the following remaining topics of Chapter 25. That concludes my report, and these are the references. Thank you.
Thank you so much, Dr. Ariane. That was also a very good lecture. Both of the lectures this morning are exceptional, and that both of you have given us all the important points: coronary artery anomalies. And the treatment. They're very difficult topics, but you made it sound so easy, Dr. Ariane. For Dr. Khalil, truly exceptional. Thank you so much. I learned a lot this morning. I have no further additional insights to add. And in fact, I was the one who learned a lot from this morning's event. I would also like, before we end this activity, I would like to thank our dear chairman, Dr. Pasha, that you have graced us with your presence in this morning's academic activity. Thank you so much. Are there any questions from our audience? If there are none, I would like to greet everyone. Good day. Thank you so much for attending.
Thank you, Doctor.
Thank you so much.